the first case presentation by Dr. Soumya from Nizam's Institute. Dr. Soumya, are you there?
Yes, sir. Good evening, everyone. Sir. Can I start, sir?
Yeah, sure.
Yeah. Good evening, everyone. This case is about a 6-year female child. Initially presented to us and diagnosed with the right parietotemporal brain tumor in March 2025. Stage of the diagnosis is 2. Performance status at the time of diagnosis is 2. There are no comorbidities and no family history. Then diagnosis date was on 20th March 2025. She was operated on the tumor and initially it came as a ependymoma. Then after the surgery, there is a partial response. Again, the progression of the disease noted in August 2025. Then re-excision was done on 11th of October again. Initially, gross total excision was done on 28th March. Then re-excision was done on 11th October 2025. So the second time biopsy details, the site is the right temporal lobe with given as a desmoplastic infantile astrocytoma with atypia. IHS GFAP positive, CD34 positive, synaptophysin negative, molecule retain, H3G34R slash H3.G34V negative, ATRX retained, H3K27ME3 retained. BRAF V600 is positive and ALK is positive, ROS negative and PanTRK negative. Next slide, please. So we repeated a NGS panel for we did a NGS panel for this case, which came as no fusions were identified in this on the NGS panel. So we the question MTB is for systemic therapy regarding this case in view of ALK and BRAF positive.
Hi, good evening. Yeah, this is Dr. Slambarasan here. So if you go to the slide number 5, it will be great help for me for the immunohistochemistry. Yes, hold on. So this patient is a desmoplastic infantile astrocytoma, so which is DIA or DIG basically. So in this one interesting thing you need to note down to connect this with the molecular signature. So which is CD34 is positive in this patient. So whenever DIA or DIG is CD34 is positive, more than 50 to 60% of the time, you can very well expect BRAF pathway or otherwise MAP kinase signaling pathway to be activated. So in this case, that is very well correlating with the BRAF V600E mutation. So as a positive. Now there is a second confusion is going to be here, which is ALK positive in the IHC, whereas in the NGS result, ALK fusion we are not detecting. So this is also kind of little bit of false positivity has been reported. In the IHC, ALK positivity may come, but when you do in the NGS, the ALK mutations will not be present, and they didn't even respond to the ALK treatment if we give. So here the driver mutation is well established, which is BRAF V600E, and in FDA approval also for low grade gliomas or pediatric glioma, so BRAF V600E can be targeted with the trametinib kind of treatment. So you may need to consider trametinib. So we may need to start with a low dose of 0.5 mg and all those things based on the pediatric recommendation, whatever the dose is, and then you can start from there on. So that's one of the genomic suggestion. So repeating again, CD34 positive, you can expect the MAP kinase pathway, which is very well matching with the BRAF V600E. ALK positive, whatever you are seeing over here is a kind of false positive, which has been confirmed in the IHC, and even in the reports also suggested that even if you are trying to take any treatment based on the ALK positivity, the response will not be there. Okay, so that's my take-home message.
Sir, can I talk?
Yeah.
Sir, regarding the immunohistochemistry, sir, only the BRAF V600E is positive. So if the
Yes.
immunohistochemistry is positive, it should be positive. Either the NGS report has to be like reflected. Only immunohistochemistry of BRAF 600E, we can start targeted therapy with only IHC, sir. That's the question
No,
because
no, 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 no. In the NGS report, you go further down the eighth slide or ninth slide. Eighth or ninth slide. Also, the NGS report shows that BRAF V600 is positive. BRAF V600 is positive, basically. So this is for the RNA fusion. But I have seen in one of the other report that they have confirmed that BRAF V600 is positive. In another report, I have seen BRAF V600E is mentioned.
because that NGS report was showing there is no targets were there. I think they did the lung
I think
NGS.
only they have done ALK fusion, if I'm not wrong. The 12 gene they have done it, but they have done only for the ALK. They have mentioned only ALK fusion is not detected, basically.
Okay, sir. Because some guidelines say if it's BRAF V600E positive 9 immunohistochemistry, we have to do a molecular test. You have to do an NGS to
Of course.
confirm BRAF, and then only we can give targeted therapy.
Correct. Correct. You need to do it again. I think in second report, this is also another time they have done it. I hear also the BRAF V600 is positive, basically.
All the genes, sir, all the genes were done on the NGS panel, so like
AHC.
ALK, BRAF were done on NGS. No fusions were identified on the NGS after running through.
Okay,
All the
I would
Can I say
recommend you
something?
can. Yes.
In the slide which you're currently showing, we go down, diagnosis, brain, temporal region, etc. The next line says the further molecular analysis of the tumor revealed the mutation, BRAF
Yes.
mutation,
By
just below the
architecture.
first line after the diagnosis.
See, actually, they have confirmed BRAF V600G by RT-PCR.
Exactly. That is what I was saying. Thank you, sir. Thank you so much. This is what exactly I was mentioning.
So, Dr. Dinesha here. So, just I want to add a point about I totally agree with Dr. Silambarasan. So, to add a point about the ALK false positivity is that so generally ALK expression is native for so the ALK protein is generally critically involved in the development of central nervous system, and during postnatal period also we can see the ALK expression. So generally, also during reactive gliosis, when a patient undergoes brain injury, ischemia, or brain tumor resection, also ALK tends to undergo positivity. So this should be considered as a physiological false positive, and we can go with the BRAF and MEK inhibitor in this case.
This patient, just wanted to ask, this patient after the initial surgery, it was like a gross total excision or total, near total, so many terms they will use for the surgery. So whether it was completely removed or whether it is
gross total excision.
after that, any treatment was given like this 6 years old, right?
So we gave her adjuvant radiation.
Okay, radiation was
No,
given.
sir. Initially, no radiation was given, sir.
Now.
Now she has sent for our radiations.
So you're treating in the curative intent, right?
Yes, sir.
Okay. The initially only resection was done. After that, RT was not given.
Yeah.
So it was residual disease
Patient
was there.
defaulted for further treatment, sir.
So now, after how
initial.
many months or years it has again regrown now?
After 5 months, sir.
5 months now, the patients can present with symptomatic or just initially did just like imaging showed progression.
Presented with the symptomatic, sir. Headache she has, sir. So repeated
Again,
MRI brain, sir.
Okay. Now whether the disease is there with edema, midline shift, with that presentation, or
No midline shift, sir. Only the lesion recurrence is there, sir, in the same side. Edema
Okay.
is there.
So now resurgery is not done, only RT is given now. Or resurgery is done and
Like
then RT given.
re-excision was done, sir, now also.
Okay. Now also it's residue is there. For the residue, you are given RT.
Yes, sir.
Yes.
Now
Okay.
near total excision was done, sir,
So,
and sent for RT for residue.
so this whatever we talk about this BRAF mutation, this and all for later lines of therapy, no. So we have the chemotherapy either for this protocol, pediatric like either adjuvant CTRT protocol or adjuvant chemo protocol, vincristine, carboplatin, or temozolomide. I'm not sure about the pediatric chemotherapy protocol here. If that can be the given in later lines of therapies, we can use a BRAF mutation. So just want this is my thought.
Naren,
Uh,
can you hear? So, in case of an DIA, the current role of an adjuvant chemotherapy is very limited. It is indicated in an recurrent settings, and the same thing like BRAF mutations also, they are usually recommended in a recurrent setting. But for this patient, initially she was resected, and now again there is a caveat that she has not received a complete treatment initially because it was reported as an ependymoma, and now she again had an recurrence. So, and then she underwent near total resection, and then we are giving an adjuvant chemotherapy, adjuvant radiation also. So at this point of time, so we have to take it as a recurrent, and we can give an adjuvant BRAF inhibitors, or we will give once they again the disease come back.
some we know that chemotherapy has no role if it's fully excised, but here the
Yeah.
partially excised, so still along with the RT or then adjuvant of chemo, and then followed by maybe in future whether you can go for a dabrafenib or trametinib combination.
So actually,
Yeah.
for the BRAF V600G mutation, the carboplatin vincristine combination exhibits resistance, right, sir? So there is a
Yes.
complication also on this part.
We cannot say that because of that mutation it will be resistant to the chemo. So generally these mutations are the risk of recurrence is there, but because of this mutation it is not like they'll be resistant definitely to vincristine carboplatin. Since there is no chemotherapy tried, just I'm asking whether chemotherapy can be tried and then maybe as a maintenance
The thing
or
is,
uh,
yeah, if it is an completely resected, and we'll take it as an at this point of time, we'll take it as an completely
that's
treated.
what
I don't think
you're doing, like, whether the curative intent or palliative intent,
we are
or if
going
it
with
is
an curative intent only, right?
uh,
Near total excision was done, and adjuvant radiation we are giving. So, but even in that setting, the role of chemotherapy is very limited.
So this dabrafenib, what is the? I am not sure about the literature. What combination they are tried for this infantile astrocytoma with
So there
ATP?
is an
Plus trametinib.
dabrafenib plus trametinib, but the thing is whether we have to give at this point of time or when again disease come back.
That is some chemotherapy. If you are treating the curative intent, whatever they have tried dabrafenib, trametinib, I think they would have not tried in the curative intent. They would have given in the palliative intent whenever the patient had a recurrence, multiple recurrence.
Yeah. So whatever I feel that I also feel the same thing at this point of time for this child. The surgery was done, and we are going with an curative intent only, and adjuvant curative radiation was given. And whenever the disease comes back, at that time point, we can consider giving an BRAF inhibitor. That is my opinion.
I've just shared a
Mm,
paper here. So from NEGM, so where they have tried carboplastin plus vincristine. They have randomized in two groups, where they have tried dabrafenib plus trametinib in one group and standard chemotherapy in another group.
okay. So maybe
So this is in phase 2 trial, right? Okay.
Yes, it's to try.
Sir, I have shared another few papers also to our group people. Yes, some of the papers are here. And also single center study also I have mentioned just now in the chat also. So whenever they have given the chemo molecule, which is vincristine along with other combination, one arm, and another arm they have tried the BRAF V600E inhibitor, trametinib, single agent, always the single agent targeted therapy have better efficacy than the chemo molecule. So now the choice is very clear. The targeted therapy would be better than the just the standard chemotherapy.
Okay.
Okay, then if we are in the if you're treating in the curative intent, if we are going for
Then yeah.
BRAF, then how long you give?
So according to this trial, like what is the schedule they have given, we have to follow that schedule.
Okay. This would be, and again coming to the NGS, where the previously discussed that RT-PCR detected this particular mutation, but NGS is not detected this mutation. Is that correct? What we understand?
Yeah, maybe the lab is missed out the mutation. That's what I can clearly understand. We need to find out what is the depth they have done it. If they are nowadays the labs are doing at 250x, 350x, which is not at all highly recommended. And also the tissue block what they have submitted also we need to test it. So there is no harm testing one more time because
Usual
it's only
pattern
single
is
gene.
mentioned is, can you
Sorry?
go back to your NGS report?
Yeah. I think previous pages, page number 5 or 4.
So the tumor adequacy they mentioned 90%. Can you go to the NGS?
Dr. Narendran sir, it may not be only the tumor content. What is the depth they have done it? We need to know.
So those reports are actually usually they mentioned it, but here they are not mentioned.
No, may I interrupt a little? Since Ramrit here
Your voice
from
is not clear.
Mumbai, what I understand not have mutations. That's what I understand from the report. The panel does not have mutations covered. So there will be some sarcoma panel sometimes. So the panel does not have mutations covered. So that's the reason probably the NGS panel is not showing us the mutation. So it has been a confirmatory after what has happened is BRAF and ALK after IHC needs to be confirmed. So they have run the fusion panel on for the fusion ALK fusion, and then to confirm the BRAF mutation we need either Sanger sequencing or you need a real time PCR. And they have run a real time PCR and they found the mutation on that particular platform. So NGS probably has not missed because the panel has only fusions. It does not contain mutations. That's my say.
So this
Because
is
with 90,
only RNA fusion they have done.
yes.
Let's go to the report. Go to the report of that one. We may have a methodology. I think it is from Tenant Oncomine panel. They have done yes, Tenant Oncomine panel. Just go to the Tenant only. That report only.
You go to that report, back to that
Yeah.
report.
Back to the Tenant report. Tenant Oncomine report. Yes, just one more page. Okay, in this one, they have covered the. Oh, just hold on. Next slide only.
Yes,
Next.
here methodology they mentioned here.
Yeah, methodology, right? So they have extracted the 12 gene panel and they have done it. What is the X they have done it? Is there any X is
Usually the
mentioned?
12-gene lung cancer panel they have run. Yes. It is
Oh,
not like a
Okay.
full NGS. It's like a
yeah.
12-gene panel.
So
Okay,
generally
one more thing
for
I
the
will tell you.
point mutations, RT-PCR is considered as the gold standard, sir.
That is orthogonal validation, I would say. That is also good standard curve. And also, if you look at that one more thing, briefly, they have used only 10 nanogram of DNA and RNA were amplified using 12 gene panel. So, as per my lab information, 10 nanogram is not good sufficient starting material for the NGS. At least you need to go 50 nanogram, 50. So it's lab to lab vary. That's why the clinical validation, analytical validation of the quality of the lab is matters a lot. Again and again, I'm repeating. Many labs are missing out this part. So 10 nanogram.
Sometimes coverage also doesn't come. Sometimes you have the gene and there are no
But
reads on that particular gene. So that
exactly
is
the
why,
depth is not there. The depth is not
so
there.
that
So
is the
all those
without the coverage, then they go for another panel.
the depth will be there. So this is the number one thing you can derive from here. right? And then go to the next page. Okay, so they have mentioned BRAF gene is there, right? Okay, BRAF gene is
Oh,
there.
they have analyzed. Okay.
Assay genes assay for the detection of fusion. Please understand that gene assayed for the detection of fusion, not for the indels, insertion deletion, for the point mutation, nothing.
Rajkiran class, Raj.
So they didn't may not be done. I am not very sure. They may not be done for the point mutation. So they have detected only for the fusion.
Correct.
With the hope that they want to do only for the ALK fusion, basically. Okay, so that is where they have missed out the BRAF V600E mutation. So now it's a very clear evidence. BRAF V600 is the driver mutation. So we may need to start with at least single agent of trametinib. So there are multiple evidences I have shown to the panelist here. And go ahead whether you want to do it now or chemotherapy. But my personal opinion is the target therapy would be better because there are some single center studies also have proven that more than the chemotherapy, the target therapy works better for the patient.
Can I add one more point here for the ALK, false positivity? Uh, ALK, as it looks like, this antibody detects the fusions absolutely, but it also detects the amplifications and copy number variations as well. So that is why there may not be a fusion in this particular case. That is why the NGS could not detect a fusion. It could be just an amplification or a copy number change, which the antibody on IHC has detected. So, which is Simbu is rightly mentioning, this is not targetable. But definitely, if there is a copy number variation or there's an amplification in the later stage, it might lead to resistance to the chemotherapy a little bit. But that is why you could see the positivity on the IHC, but the fusion is negative on the panel. Yeah.
Okay, so this particular patient definitely BRAF V600E. We agree that the point mutation is there as the PCR has detected it, and AL fusion is not there. And regarding consensus for what is whether they go for chemotherapy and reserve the dabrafenib and trametinib at later lines, or go for dabrafenib trametinib, there are mixed of consensus there, and so both are options. So finally, maybe we will have other experts' opinion also, and we can revert back. As of now, there are mixed opinion. So we will have other consensus opinion also. We will revert back to the presenter in 1 or 2 days.
Okay, sir. Thank you, sir.
Okay.
Now I'd like to invite Dr. Joseph from KMI Chennai for his presentation.
Ours is a patient, 49-year-old male, and he was a known hypertensive. He presented to us with high-grade fever for the past 2 to 3 days in the last week of October 2025. During his admission, he was found to have splenomegaly around 13 centimeter was a total spleen size, and his labs during admission were HB was 9, TC was 2820, absolute neutrophil count was 1015. Platelet was 60,000. There were no bleeding manifestations. LDH was in the normal range. Fever profile was negative for this patient. Infectious causes of fever were also ruled out, and APLA panel was found to be negative. Peripheral smear showed occasional teardrop cells and macrocytic normochromic RBCs, giving an impression of macrocytic anemia with leukopenia and thrombocytopenia. This was an impression by peripheral smear. In view of delay in recovery of counts, he was taken up for bone marrow aspiration and biopsy. Aspiration was hypercellular marrow with erythroid hyperplasia with megaloblastic reaction. It also had binucleated erythroid forms. Pearl stain was 2, blast was less than 1%, and plasma cells was 2%. Bone marrow biopsy showed increased cellularity and 1% of ring sideroblast. We had also sent cytogenetics for this patient, and he had normal karyotyping. NGS was done that showed ZRSR mutation, which is likely pathogenic, and ETV6 was likely pathogenic, and TET mutation was variant of unknown significance. When IPSSR was used, it gave a score of 2.5 points, which is low risk. and IPSS-M showed 0.18, that is moderate low risk. Currently, the patient is asymptomatic and his latest counts are HB is 8.7, TC is around 3,200 and platelets is 90,000. Currently, the patient is asymptomatic.
Just to sum up what Dr. Lakshmi said, now this was a patient who was admitted for a febrile illness with the radiologically enlarged spleen. The spleen was not clinically palpable and pancytopenia to begin with. Now, initially, the pathologist told us that there was some dysplasia mainly in the red cell lineage. So that is why we did cytogenetics and we proceeded with NGS. Now, the NGS shows two abnormalities, one of which is strongly consistent, the ETV6, one is strongly consistent with MDS, MDS AML. And now the patient is clinically better. Counts have not fully recovered, but are showing a recovering trend. The platelet is 90,000. The challenge was, do we take this NGS report and go ahead and treat asymptomatic patient? Because labeling someone as MDS and once we start them on hypomethylating agents, then it's a kind of a very, very long process. We cannot really reverse back. Or do we just wait, or do we repeat the test again and then take things forward? That's the challenge right now.
But what is the risk stratification he comes now, sir, as per the criteria?
By IPSS-M, he comes to what is called moderate low risk, which is a 4.8% transformation to AML over how many years, ma'am? Just a second. Leukemia-free survival, 4.5 years. Overall survival is 4.6 years median. AML transformation is 4.9% by 1 year.
Okay. Silambarasan sir, you want to take regarding NGS, you want to comment? Your expert
Yeah.
comment.
Okay, sir. Sir, actually, just I want to let you all the entire panelists and the presenter over here, just to let you know, I'm not an expert in the hematological malignancy, so I may not able to touch it up very connecting the genomic dots with the hematological malignancy, but I can show some kind of information related to the genomic things. So if you go back to the NGS report, just go back to the previous NGS report. Yes, okay. So here there are two mutations has been identified. One is ZRESR2 and another one is ETV. And as usual, always I used to see the clinical feature, whatever we understand, connecting with the genomic information need to correlate very well. Then only the molecular biology will match with the clinical feature. So in this case, the ZRSR2 is little bit of matching for me. I am not very sure about other two mutation, but that is ZRSR2 mutation, which is a loss of function mutation, and it seems to be the predominant clone also in this population. Why I'm saying this is very important is this is involving in the erythropoiesis process very importantly. This is the spliceosome molecule. This gene is involved in the spliceosome molecule in the erythropoiesis process. So erythropoiesis, this is plays a very, very key role, vital role. And if you go to the blood report, I think we have the blast and we have that lymphocytes and all those things, right? So that report, that area. And next page, I think blast is 1%. Yes, correct. In this one, the blast 1%. Just yes. In this one, if you look at that, erythroid precursor is 40%. So this is where the erythroid process is hammered mostly, and that is very well matching with that particular gene. But the treatment wise, I'm not very sure. So as I mentioned, I'm not hematological malignancy expert. So only thing what I'm seeing is that the gene, whatever we identified the mutation, which is very well matching with the erythroid process, halting the process. So that could be the possible reason that we are seeing it. Other than that, connecting the dot with the treatment, I'm not very sure. So some other expert made it better than me. I will leave it to them to take the next judgmental decision, whatever it is, just for this patient.
Hi, Dr. Dinesha here. I just want to add a point based on the NGS perspective. As Dr. Silambarasan mentioned, the ZRSR2 VAF is about 74%. So this gene is actually located in the X chromosome. So being male, so which shows that about 3/4 of the cells harbors this mutation, and it also phenotypically matches with the kind of disease phenotype what they have the patient has exhibited.
Yeah. I think Dr. Raj's question in the chat box is something that I
Yeah.
have been considering also now, but is it a what is
No,
called
no. It could be chip or not. That is what the question is about.
This is
Sir,
not
the chip is about actually clonal hematopoiesis with intermittent potential. That is called a chip. So the chip, there are certain genes are involved to be called in the chip category, and also there are VAF cutoff is there. So the VAF cutoff here is already more than 74%. So if it is less than 3% to less than 5%, we will consider as a chip molecule. Whereas here it is more than 74% as it said, so it may not be a chip one, so it can be now considered as a CHOP. So clonal hematopoiesis with oncogenic potential. So that is why it is called CHOP. So now it is more than 74%. So definitely it is one of the driving factors for the erythropoietic lineage. Erythropoietic lineage.
okay?
So may I also add a little bit on this situation? Now, these particular mutations, they are definitely, looking like a tier one, and they are associated with the MDS AML type of scenario. Definitely not added into any of the revised classifications for the prognosis, but and the patient is doing normal. So in the meantime, if we do a germline testing, take a buccal swab and see if these mutations are germline, and if they are germline, you have to, really measure them, monitor the patient more closely, and if the counts goes high in the meantime, I think you'll have to start treating. Out of this, there's ZRS2 and TET. They absolutely look like a pathogenic and germline. So I would kindly suggest you to do a germline testing and start monitoring the patient more closely. And about this ETV6 variant, it is contraindicated. I mean, it is a contradictory. Some people have called it as VUS, some people have called it as likely pathogenic. So the variant does not have very significant in vitro data for classifying this as tier one. So probably if it is a VUS on germline, that is out of the danger. But I think ZRS2 and TET2 combination, of course, single mutation is not very dangerous, but the combined mutations usually lead to the secondary and the tertiary more number of mutations in the form of a evolutionary, pathway which happens. So I think the treatment is not likely right now. We can observe, do a germline, and then based on that, we can keep monitoring more closely. Yes.
No,
And when
this
you say germline, can I
ETV6
take a
is
second?
yeah. Yeah, go ahead, sir. Sorry, sir.
Sorry. When you say germline, you mean a whole exome sequencing, or do we look at the hotspots which are very similar to this? Or
When I say germline, it means we want to understand if the mutation is hereditary or this is acquired. So when I say germline, so we need to take the patient's original cells. So buccal mucosa sample is something which will give us a true picture of the present scenario. We do not know this mutation from the blood is acquired or whether this is hereditary. In the blood, we cannot define it. So we want to define this is patient's own genome. You don't have to do whole exome. Just pick up these mutations, take the buccal swab, and send for Sanger sequencing of these particular three mutations. That's all. That will be more than enough for you.
okay, thank you.
So,
Sorry,
but these are the fun from the bone marrow, right, sir? This sample is done from the NGS from the bone marrow, right? Or
yes.
bone marrow sample. Then bone marrow sample more of like pathogenic, like, ma'am. You wanted to confirm it by buccal mucosa.
Yes, I would like to because yes, and all these acquired mutations, all these fusions happens in the bone marrow. They starts in bone marrow. If you look at all the AML fusions, mutations, It's not necessary that they have been inherited from the parents. It's acquired. Yeah.
That's what this is done from the bone marrow. So the more chance of being acquired, right, than into the hereditary. It is mostly it will be like
It's
acquired mutation.
acquired. Yes, it is acquired. So
Still, we
that
have to
was
check.
yes, that is why we have to check. Yes, thank you. Yeah.
Hello.
Yes.
Yes, that's the reason we need to check on buccal mucosa that whether this is
Only we have
germline
to
or
check.
not.
Okay, so the question here is if it's done from the bone marrow, it's most likely it is acquired, right?
Right.
Then most likely acquired means because the question here is the question of discussion here from clinical aspect is sir wanted that this is a classification. Usually, what we traditionally we do is MDS classification. It doesn't incorporate this ETV6. It doesn't incorporate this somatic mutations. So usual risk is low, but the somatic mutation makes it high. So how clinical significant this mutation? Because one mutation it says lower risk, another mutation says a high risk MDS, high risk of transformation to AML. So that is why the discussion is still here. We take this as a somatic mutation. We don't want to do a buccal swab here, or you wanted to do buccal swab, prove it as a germline, and then to proceed further. This is a question.
So, Dr. Narendran, I will share my take-home message. So here, first thing is it's a somatic mutation is proven because you are done it in the bone marrow of the patient, affected individual. Okay. But now, since the work percentage is more than 73 or more than 50 percentage, you want to now consider whether it's a comes from the germline also. So for that, I would recommend even normal the blood sample, EDTA blood sample, go for the clinical exome sequencing or whole exome sequencing, which is only 8,000 rupees to 10,000 rupees. So that will prove that this is a germline or not. Because in the blood, we will be doing only from the BBC cells.
Conundrum, I will just interfere. In
Mm,
hemat, for
mm.
germline, we do not use blood samples.
It's buccal
For
mucosa is
hem,
better.
it is buccal
Ah,
mucosa. We do
buccal,
not
we can
use
do it.
whole
Yes,
exome. No, no.
buccal
That's the.
mucosa. And these panels, sorry, sir, myself
Mm.
here. These panels they are available in smaller hemat panels also.
Also is
We
there.
need
So we
not
can
do
do that.
big panels for this.
Yes, we can
Uh,
do that. So
and it's cost effective.
ultimate goal what they are trying to do, we will take the normal cell. Buccal mucosa is a normal cell. So when we do normal cell, if the mutation is still present, then it is considered as a germline. That is the ultimate goal
And
we want to prove.
not only that, Simbu, more than anything, it just not the mutation. We
Hmm.
also have to look at the family history. Such mutations don't happen just like that to anybody. So, in the current scenario, if there is no family history and the age of onset is late, very unlikely these were predisposing alterations.
And Dr. Vidya, it could be the primary first generation also, it could get this mutation. So
But
next generation onwards, it can be starting also. So that also we need to find out. Even though sometimes the family history may not be present, but this could be the prime suspect, the prime first patient in the family. In the future, it may develop also, right? So that also we can consider. But I agree with the
with
buccal
in
testing.
the seventh, sixth decade of life, and nothing happened so far with these loss of function alterations. We should never look at genetics standalone, I feel. We should
Yeah,
always
definitely.
correlate with the family history and then only come to a consensus that it requires. So, main thing is, should we spend that money for the patient? That is one question. Because even if we found it, how is it going to help the doctor? Right?
Okay.
That is also
So,
one more thing we have to look in short, as you said, these are not sorry.
Go ahead, go ahead.
Yeah. So what I feel is what sir has told, based on the IPSS criteria, it comes as low risk category. These mutations or these clones are not going to fade, sir, over a period of time. If they fade or they don't fade, we can look at it as a periodic assessment because according to you, his pancytopenia is improving. without giving any intervention, it is improving right now. And you also feel clinically it is a low risk category of MDS. When an intermediate will become high risk is particularly when you have a deleterious alteration either in cytogenetics or in the mutational profile. So in this case, cytogenetics is normal. We don't see any big time chromosomal challenges happening there. And we don't see a TP53 here. If we saw a TP53, then we have to worry that sooner or later MDS will transform to AML. Here, I feel we have to watch, because clinically also it matches. In symptomatically also there is an improvement with whatever treatment you have given. Maybe 6 months down the line we can check the same panel without changing what happens to these clones. If you feel intervention is not required based on the clinical recommendations.
Dr. Vidya, I agree. So if that is the
Perfectly.
scenario, even I would recommend that in MRD testing is available nowadays for this clonal population. So this clonal population, we can closely monitor whether this VAF percentage is coming down or not, basically.
But
So
you
that
know
is
what?
also
This
another
VAF
option.
will be dynamic. As the patient ages, MDS remains like a chronic disease without interfering with the lifestyle. Right, sir? For a very long time, sir. Joseph, sir?
Yes, low risk MDS does.
Does no, sir?
For a long time, yes.
Yeah. So
But
these
at least
clones
the
might be
MRD
dynamic. Yeah. See, whether we do an
dynamic.
MRD or not, this panel by itself will give an answer to us, I feel. Another marrow aspirate after 6 months, maybe, means from the time you diagnosed, because already it's now 3 months over. So maybe another 2-3 months we can wait, and we can use some regular clinical hematological examinations as a routine monitoring, and then ask for a marrow again and look for the same panel. If there are, and sir, if we want to see a clonal evolution or if there is a disease progression, we may want to look at a slightly broader panel, sir, because the information what we got today is limited to the current clinical condition of the patient. Suppose we see a modification in the clinical parameters, we may have to go for an elaborate panel, sir. That's what we feel, sir. Okay, sir.
Joseph, sir. Joseph, sir.
No, I'm here.
Sir, just wanted to know this IPSS-R is a low risk and IPSS-M, there are two classification is there. As of now, we follow the guidelines based on treatment based on IPSS-R. But if there is a significant increase, suppose if it's a low risk by IPSS-R and if it's very high risk by IPSS-M, then we can go for treatment and then followed by transplant. Since it is progression to AML, is there's larger risk of progression to AML. So this patient IPSS-R is low risk, sir.
Yes. And IPSS-M becomes moderate low risk.
That I think we cannot calculate. It's like they give by based on the multiple genes they give. It's like a calculated risk. I think that is we cannot calculate manually, I think.
Yeah.
So it is still it is in the one step higher. It's not like a very low and high. So what my suggestion is that, so here we can follow the patient closely, but we can explain him that there is ETV6 is there, which is chance of progression to AML is there. So as of now, we follow closely. And once if it is the clinically the parameters worsens, then we can do a marrow again. At that time, as per the expert's suggestion, we can go for a broader panel, look for any other clonal evolution is there, and go for a hypomethylating agent followed by transplant based on at that time risk. Sir.
Okay.
This is what I think.
Yeah. So agreed, Naren. So since the patient is not having clinically significant cytopenias at this point of time, we'll follow up the patient. So we'll go with the next case presentation.
Thank you very much. Thank you.
Thank you.
So I invite Dr. Ramakrishnan from Meenakshi Mission Hospital to present the case.
Good evening, all. I am Dr. Lakshmi, presenting in behalf of Dr. Ramakrishnan, sir. So, we have a 68-year-old male patient who is initially diagnosed as a CLL. Later, for persistent bleeding per rectum, he was diagnosed as carcinoma rectum. Stage 3, that is clinically T3N1 disease, with no significant family history. Next slide. So initially, when diagnosed with CLL, he was started on ecallabrutinib, and later, or 1 month later, diagnosed as rectal CA rectum, clinically T3N1M0 adenocarcinoma. Then planned to he started on Longos-RT with capecitabine, and we have done a whole exome genome sequencing for this patient, which showed APC exon 16, a variant uncertain significance. Next slide. Next slide. So our this is the whole exon sequencing report, which shows APC mutation in exon 16, which shows an uncertain significant mutation, variant of uncertain significance. Next slide. Next slide also. We have done a stress cytogenetic study for CLL also, that shows no dividing cells were obtained for the culture, no specific finding on this. Previous slides, that question part. So our question is significance of APC mutation in the context of this dual malignancy. Does APC VUS contribute to both to CLL and rectal cancer? Does it alter any treatment strategy or surveillance for this patient? Now he completed the neoadjuvant long course RT, sir.
Just wanted, before go to the experts' comments, just wanted to know any family history of cancer in this patient.
No, sir. No, sir.
No family history of cancer.
No family history, sir.
And number of polyps while doing the scan.
Any colonoscopy, either completion colonoscopy done, the rectal lesion is there, whether you have looked into till the cecum, you have looked into completion colonoscopy, any reports is there?
1 minute. Only rectal growth is there, sir, in colonoscopy.
They have done the completion, they have done up to cecum, they have done a scopy. Because in most of the rectum, they may not be able to do up to cecum. Later stages, they may do completion colonoscopy.
Yes, sir, up to cecum, terminal ileum, up to that part.
Okay. I would like some experts' comments on both the reports before going for clinical comments.
Yeah, just go to that NGS report, APC mutation.
Next slide. Before.
Yeah, so this is only the clinical whole exome sequencing is done with the intent of germline testing actually. So
Yes,
far
sir.
we not established anything whether this mutation is in the somatic tissue samples also or not. So my first humble suggestion is go ahead for do the somatic testing. Because with the germline testing, we cannot take any clinical decision, especially with the APC mutation, we cannot do anything much about it. So
Okay, sir.
first thing, you may need to do the tissue sample of the colonic sample, go for the somatic testing of at least the colorectal cancer panels. So that the APC mutation, what we are identified over here, whether it is in the somatic thing or not, one thing. And
Yes, sir.
the second thing is that it's a APC driven colorectal cancer is there also. There is not much direct treatment options are available. Only one latest evidence is suggesting that APC mutations are Wnt signaling pathway. Aspirin drug have little bit of efficacy. That is only PIK3 mutation, not for the APC mutation, but PIK3 Wnt signaling pathway having connected. So that is one or off label. There is no standard of treatment with based on the APC mutation is present. So that's a direct message. So we will hope for well establishing the driver mutation in the somatic testing. And from there onwards, if we can able to find out some pathway, then we can able to target the further patient while doing the treatment. So with this report, there is no target options are available. So directly we need to go for a somatic testing.
As per actually, for this stage, we don't target any mutation. So only for
We cannot target.
MSI is there for immunotherapy for the curative intent treatment. There is no other targeted therapies used. But the question here, since it's a APC is uncertain significance, so their question is, this is a whole exome sequencing they done. Whether this VUS has to be checked, verified, and whether the family has to be checked, whether that is their question, whether genetic counseling has to be given, that is their question.
Yes, Dr.
Any
Narendran, sir.
effect on CLL treatment, sir?
CLL, I'm not very sure,
Yes.
ma'am. To be very honest, as I mentioned, I'm not a hematological malignancy expert, so I'm not very sure on that.
No, there is no effect on CLL treatment.
Effect on CLL. Okay, sir.
And what is the difference? Instead of here, we would have gone with the hereditary cancer panel, germline hereditary cancer panel. Why it is done with the whole exome sequencing? Because two malignancies is there you wanted to go for, whether that will give an additional, just wanted to know from experts.
That could be the possible reasons. Only the clinician could explain why they have done it.
Whether what
additionally we could done over here is whatever they have done because of the dual malignancy, especially hematological as well as the solid tumor, they have done it. So clinician wise, they are okay. That is good, a good approach.
Any syndromes, genomic instability syndromes.
Genomic instability syndrome, all those things they want to rule out. And on top of this, what we may need to do is now we need to prove this APC mutation is the VUS mutation. We need to prove whether it is already mutated in the tissue sample also, so that we can consider this as a likely pathogenic. Then the genetic counselor will come into the picture, whether with the pedigree analysis, we need to see whether any family history of cancer is there or not. Then only we can consider for the genetic counseling. At this moment, treatment part, there is nothing is there. So first, establish this APC mutation as a likely pathogenic mutation. From the VUS, we need to move them to the likely pathogenic.
Okay, sir.
Yeah.
Actually, this mutation is located in the mutation cluster region of APC gene. So that is one thing. But mostly in the sporadic cases, the APC gene mutations tends to be truncating. But in this case, it is missense mutation. Also, the patient is aged about over 60, I think, and also there is not much polyp. So we can rule out the possibility that this could be pathogenic. But what I think is that this could be a low penetrant risk gene. But like what Dr. Silabarasan mentioned, unless we do somatic testing, we cannot come to any conclusion.
Okay, sir.
This is done in
So
the blood,
does
right?
the family has a history of cancer, colorectal cancers? Does the family has any history of colorectal cancers?
No, ma'am.
No. So being a missense mutation and a low penetrant gene, no particular data. So I will not emphasize more on APC even as a prognostic or a predictive marker. That is my say on this particular gene. Yes, as Simbu said, you can do a somatic testing and see if the patient fits for cetuximab therapy or not. That is an option that you can look into. Yes, there's a deficient immune system, and and if the patient has a secondary malignancy, that usually progresses faster. So this is my observation, but I think the treatment what you are giving for CLL and capecitabine or probably cetuximab later will be able to help the treat patient better. Yeah, with no family history and patient having no polyposis or syndrome or anything like that. Yeah.
Okay. Thank you.
Lakshmi, this patient, the whole exome sequencing is done in blood.
Yes.
Yes, sir.
Okay.
So, sir, from my side also, I feel this variant does not require any further concern, because as of today, the literature is VUS and the patient has no family history. Who are we screening to upgrade this variant, because when there is no family history, you don't have a phenotype to phenotype mapping to look for upgradation of this discovery. And so these might be two sporadic events that must have happened with this patient.
And I think the drug interaction between the with acalabrutinib and the drugs which are going like capecitabine, what you're going to use 5FU might some have impact. So we need to check the drug interaction also in this patient.
Okay, sir. Sure, sir. Sure, sir.
Yeah.
So as per all the opinion, this patient, you go ahead and complete the treatment for CA rectum. And since the patient has indication and you have started on acalabrutinib, probably after the treatment of CA rectum, you can continue acalabrutinib.
Okay, sir.
MYD88 has been verified, madam.
1
The
minute, ma'am.
classical CLL markers, no, 3-4 of them are there, right? So in future, when you want to see the response to acalabrutinib, we can
Okay, ma'am.
look at those mutations in the CLL panel. It's a very small
Sure.
panel. If there is a need, then we can use that for the CLL verification.
Sure.
Yeah,
Sure.
very good suggestion. Yeah.
Yeah. Otherwise, even you did the germline, and the germline, the whole exome is usually done at less depth, about 100x. But if we want to pick up somatic mutations, we have to send it for the CLL panel. So I think Medgenome has one CLL panel also.
Okay, ma'am.
Yeah, that small
Actually,
panel
this
can check
patient
that.
already on CLL treatment, now CA rectum diagnosed. So their discussion for CA rectum.
Oh, okay, sir. So in that case, anyway, you are going with the classical standard of care rectal management, rectal
Rectal
cancer
management.
management, right,
Yeah.
sir?
Yes.
Yes, sir.
Thank you. Thank you.
Naren, can you present your case?
Next slide. This patient is 45-year-old male with the ileal gister. The patient presented with the bulky disease. So the surgeon wanted for a neoadjuvant strategy because initially it looked like an inoperable disease. So we have started on imatinib. Next. The biopsy was c-kit dog positive is a confirmed suggest. So we have started on we have sent a mutation profile, and then we have started imatinib. Meanwhile, the mutation profile came as the next slide. So this is that specifically the just a mutation profile. So they have looked for all the mutations. So here the c-kit is negative, and the PDGFR is negative, and other BRAF mutation and other mutations are negative. The mutation was checked here, and the STH deficiency we have not looked into the IHC. So only the mutation is checked. So this patient, since there is no mutation present, we went ahead with the surgery. We didn't continue imatinib. And now our plan is to keep under follow-up for this patient without any therapy. So the question, can you go back to the question? So in this particular patient, what could be the oncogenic driver if all these mutations are negative, and whether we had to check anything else, because the tumor content is good and the adequate panel is done. So again, whether this prognosis wise, how it is different from other. Only thing we have not done is the STH deficiency. We are not done by IHC. So any suggestions for these questions?
Broad panel will be the only option to look if there were other drivers, sir.
So what are the drivers we have to see, ma'am, in this case?
HER2. HER2 is one option is there. Is it HER2 is covered in this one?
No, it won't be, because this is GIST, right? GIST will not have classical, all the classical ones are covered. And is this a hotspot panel or it's a full gene panel? That is one more thing we need to verify, sir. Because although nature makes 9 and 11 exons, at times there can be neighboring drivers. which
They,
are
they have
driving
looked
this
into all
disease.
the exons, exon 9, 11, 13, 17, but
Ah,
I don't know whether the other exons like exon 8 and other
yeah,
9, 11, 13, 17
14.
has been looked into here.
Okay. So uh, we can look at a kind of a CGP like approach, sir, to know the disease biology better. Because you are telling it's a bulky presentation, aggressive disease to begin with. Histology wise, is it having a poor differentiation or how was it, sir?
What differentiation is there's no this one necrosis was there. We don't know imatinib whether worked or not. We don't know because the size of the sample is same. We have just started 1 month. We gave imatinib, and since the mutation came negative, we immediately jumped into surgery.
Okay.
So
Because there is an increased c-KIT expression.
that's what the c-KIT expression is there, but this is negative. So what
Mutation.
is making the driver here? We went did a literature search. They suggested for STH deficiency also can be c-KIT positive. That has to be checked with IHC. So other than that, some suggestion is that we want to check whether the adequate coverage was done, whether all the exon was checked. So these are the two suggestions were there.
Go to the
So
methodology session.
Instead of doing small panels, once for all, a broad panel will better.
Yeah, broad panel we need to go, but just also check it out. The test methodology.
They didn't give the
Test methodology.
further down. Further down. Scope
I
of
think the
testing.
methodology is
It's not given, sir.
Yeah. Sometimes
Further
also
down.
you check it out.
They have not mentioned.
Yeah, so coverage may not be sufficient enough. The depth I need to say. Anyway, as Dr. Vidya have mentioned, we may need to go for a little bit of bigger panel. So that will give you a lot of additional options. And we can establish the disease biology. What kind of driving mutations are there? Also, things we can able to establish. So as of now, there is no mutation is discovered. So I don't have any comments on it. So you may need to go for one more genomic testing from different lab or from the same lab for the bigger panel, so that that could establish the driver mutation in this case.
okay, sir. Thank
In
you.
addition to the larger panel, you can also check for STH deficiency in this case, sir.
IHC. By IHC method.
By IHC.
Yeah,
And also
STHB alone.
make sure your broader panel also includes RNA fusions.
Yes.
SPH deficiency by IHC, they do routinely in all the labs. Just wanted to know.
Yes, sir. You can do that. If you have not done that, you can do that, sir.
Okay. They do it regularly here. Any labs they do it. IHC,
HCG, I mean, Bangalore HCG, they do it, sir. I know. That's a, second opinion center, right? They have many IHC markers. The Trust lab in Bangalore, they do it.
Okay. Thank you.
Yes, sir.
Thank you. Thank you all.
Yeah, now we'll go with the case 5. I would like to invite Dr. Arun Seshachalam from GVN Hospital to present the case.
Actually, Arun sir is not there. On behalf of Arun
Yeah.
sir. Sir is there?
No, sir. I'm
Behalf
Dr.
of-
Lakshmi, sir, myself presenting the case, sir.
Okay, go ahead.
So we have an 80-year-old male initially diagnosed as CA pancreas stage 3 at 2015 with no family history. Next page. Next slide, please. So in 2015, he underwent Whipple procedure and received adjuvant chemotherapy abroad, but details was not available. Currently, he is in October 25. He is found to have the progressive disease. Next slide. So the biopsy from the left psoas muscle shows a metastatic adenocarcinoma deposit. Next slide. So this is the previous. Here, so he is found to have the HRD positive with BRCA mutation. Next slide. Next slide. This is the biopsy report. The previous questions, please. So further management options for this progressive metastatic pancreatic adenocarcinoma. Sir is planning, considering his age, 80-year-old, HRD positive, BRCA positive, stage 4 pancreas. Sir is planning for weekly carbo, then PARP inhibitors. What is our panel suggesting, sir?
Okay. Just report of
Yeah.
So there is a biallelic
So
BRCA tumors.
yeah, that's what first I
One
want to
could be
confirm.
one could be germ-line, the other could
Yes,
be somatic loss of
correct.
phase. So as Sir is planning, Sir can go with the weekly carbo with PARP inhibitor.
Can you go to the, can you have a discussion on that NGS report, sir?
Yeah.
Yes.
Can someone
So
display the NGS report?
yeah, first display the NGS report, then we will go to that evidences. Yes. So in this one, first one is borderline 43%. So this could be possible of a germline. So that we may need to check it out. But still, both the mutant, if you look at this BRCA2, this is 2434 position. So that is coming approximately, I think, exon 12 or exon 13 it is coming. And it's a termination mutation. So it's a loss of function, basically. So BRCA2 loss of function in pancreatic cancer, 1 to 2% would be a driver mutation. And there are two different clonal populations of mutations also there. The second clone also, considering 14 dominant clone also. So first clone, it could be the BRCA2, which is the 2434 position from the exam words. So that could be the possible reason. So from this one, it's very clear evidence that BRCA positive pancreatic cancer. So now how to go ahead for the treatment part? There are two, three options will be available. One is platinum-based treatment, or another one is PARP inhibitor-based treatment. So PARP inhibitor, only olaparib is approved for the NCCN guideline. There is no other options are available. Niraparib and other things are ruled out. So only olaparib is approved in the germline BRCA mutated or this kind of high allele one. But there is
I
one
think
more
rucaparib
interesting
also,
option
sir.
also there, and rucaparib recently
Rucaparib
approved.
option, rucaparib is this.
Recently is there. But if you look at the data of rucaparib and olaparib combination, the percentage of the germline mutated, BRCA2 mutated in the olaparib clinical trial, which is a polo clinical trial, is more than the niraparib one. If my memory serves correctly, that is the case. Okay, so anyway, PARP inhibitor you can consider is a little bit of second option. But before that, there is one more interesting option I have found out when I was going through this case. Can you show that case, that paper publication I have shared? Yeah, maybe the fall for yes, this one. So BRCA2 mutated pancreatic cancer, they may have the good response with FOLFIRINOX also. So this is another option for the clinician if they want to try. There is also another option because oxaliplatin also platinum-based treatment and they are responding very well. Not only one article I'm sharing here, there are 2-3 articles have clearly shown that FOLFIRINOX is a good option for this patient also. So the clinician, when they are going for chemotherapy-based regimen, either they can go for a carboplatin-based treatment, or they can even consider oxaliplatin-based treatment also, basically. And after that, based on the patient's response, if it is more than 6 months and all those things, they can even consider for the platinum-based PARP inhibitor in the later setting. So first option is, one more option I'm bringing to the table is the FOLFIRINOX, basically for this patient. Okay, there are other evidences also there. That is not only one evidence I'm bringing. There are a few more evidences also. They have shown that FOLFIRINOX may work for the patient. Yes, this is also another group of study they have done it. The response is also much better than the normal platinum-based treatment.
So this patient, 80-year-old,
8 years.
we will not be
Also
able to give
tolerability.
Tolerability, yeah,
also we have to
tolerability.
give for the
Yeah.
weekly carbohydrate followed by
Single.
olaparib.
Yeah.
There is
So that
also
will be the
another regimen
ideal.
is there. There is another regimen is also there. Modified FOLFIRINOX also there. I think low doses was reduced, but as you rightly said, the patient is 80-year-old. They may not be able to tolerate also. So we need to
Kind
consider
of
whether we can.
platinum followed by PARP inhibitors. That will be the best choice. Which
Better
the
choice
platinum which can give us that weekly carboplatin is the only thing we can give. The patient is a
because of
doctor.
the 80. Okay,
So that's
okay.
why this is. And this BRCA mutation 2 allele, you said no, sir.
Yes.
So this 2 allele, one is a germline and another is a somatic acquired. That is what we can interpret from here.
Possible.
Not somatic.
It's only predicted.
Acquired only I'm talking about. That's
Mm.
predicted. Only it's predicted that two clone populations are there. Whether it is acquired or naturally it is present as a two clonal population, we don't know. We don't know.
Germline has to be done.
It need to be tested, but
BRCA1, BRCA2 germline, if we do, we will get that answer.
correct. That is the next way to go forward. But
Yeah.
at this moment, at least we need to check it out in the family history. Is there any other patients have affected with cancer or not? That's a simple strategy we need to start first, and then go ahead with the germline testing of BRCA1 and BRCA2.
Okay, this patient germline genetic counseling and germline BRCA1 and 2 suggested by the panel, and also some kind of platinum for his age, weekly platinum, weekly carboplatin,
Yes.
and followed by
Yes.
PARP inhibitor.
Is there any serum biomarkers you have to monitor his disease?
I think sir would have done a CA99, and so that is not given here. But
Elevated?
usually we monitor with CA99, so that would have
The
been
reason
done.
why I'm asking this question is because he got this disease in his, like after 70, right? Because now he's 80, and so he got it 10 years ago when he was 70.
Yeah,
At
Right?
that time, surgery was
So,
done. Now there is a recurrence.
yes, sir. So this recurrence, is it a very bulky, abundant disease, multiple meds, or it's a very small growth in one place?
That information we don't have here.
I think
Based
it's
on the
oligometasthetic
imaging,
state.
if if we know,
I think it's omental meds, probably oligomeds.
okay, sir. So there is also one small fraction of patients, right, sir, who are HRD positive and with an underlying BRCA being positive, but their phenotype may not be classical phenotype of HRD being positive. So if platinum response is there, it's an indirect indicator for us that this is a biologically HRD positive disease. That is one more learning which we can think when we are looking at this case, I feel.
Dr. Vidya, HRD score is also positive in this case.
Yes, sir.
Yes.
HRD, so there are many patients that with strong family history and without also, sir, where because this HRD is determined at the DNA level. Correct, sir. So not everything, particularly with this entire story around the myriad test of BRCA, there is another many sessions I have seen even with the pharma companies, some of the doctors also presenting. Not every pathogenic frame shift alteration which you get from ClinVar. So both of them are terminating mutations in BRCA. So if we go by textbooks, they both are loss of function mutations. So technically means what we understand, they should generate a BRCA HRD positive phenotype, meaning the HRD deficiency should be there in the tumor at the protein level, at the biology level. But there is a proportion of patients for certain mutations, particularly the N-terminal mutations, where we have seen that they don't respond to PARP inhibitors. They may respond partially to platinum, but they don't respond to PARP at all sometimes. So the platinum response is also not so great. They develop progression soon. So this is just a learning that I'm just sharing based on some 4 or 5 cases I have discussed with some of the doctors where they had family history BRCA positive and HRD positive from myriad also, and still they didn't get the response. So when we are trying, meaning now that CA19.9 or something is there with us, and if the platinum response is good and it's drastically dropping, then we know that this is a platinum sensitive disease. So down the line, there is a good hope for us that PARP also may work.
Okay, thank you, ma'am.
Okay,
This
Dr. Narendran sir, just for an academic interest, I'm telling, in this case,
sir.
if the patient is not 70-year-old, if the patient is only 40, 45-year-old, so you will have one more treatment option as we discussed earlier. So in this case, I agree with you. Since the patient is 70-year-old, so we don't have any other option. Weekly paclitaxel regimen is good enough. Carboplatin regimen is good enough. But in this case, if the case in the future, if the patient is 40, 45-year-old or less than 50 and they are fit enough, even you can consider folfirinox also in the future,
Yes,
even
sir.
modified folfirinox also. That is only purely for academic purpose. Okay.
Yeah, sure.
Okay.
Okay, so this patient, as we planned the weekly carbo followed by PARP inhibitors and genetic counseling and germline BRCA to consider. If it's positive, then we have to confer genetic counseling and other members to be checked.
Correct. That's it.
So we
Okay.
have completed 5 cases, I think, sir.
Yes.
So that article, any glimpse you can tell, sir, or we'll close it off, sir?